College of Endo. He is a member of RSSTI. He's a renowned speaker in the national and international stage with a lot of publications. Thank you, sir.
Thank you, Jason, and thank you, Dr. Pradeep, for inviting me here. So before I start the topic, may I ask other speakers, how many of you are using CGM in your practice? Of course, because so okay, the topic is not relevant because many of the audience probably haven't tried it, but it is something that we'll have to use because the patients are now coming up with the query that I want to use a CGM device, how do I use it? So Dr. Julia has already covered all the basics that we need to know about the CGM. I'll talk a little bit in details about how do you interpret the AGP reports and how do you interpret data and how do you apply them to interpret this. These are my disclosures. So as of now, there is nothing to disclose financially for the particular talk. I tried to use some AI tools for doing some illustrations, it did not work out well. And the content is largely from Dr. Manoj Chawla. So Manoj is the person whom I feel is the best speaker to talk on this topic. I heard him many times and learned talking from Manoj on this particular aspect. Maybe the Manoj is charging heavily nowadays for speaking, that's why they have to find an alternative speaker, that's why I give the chance. So, as Julia spoke to you about the CGM, now we know that CGM gives you the glucose reading continuously, and you have a huge amount of data that is coming up. So, throughout the day, you will have a number of data points that are recorded by the CGM devices. The Libre 2, which is going to be launched tomorrow, I guess, in this conference, it will measure the blood sugar levels every 1 minute. So, 1440 readings per day and lasting for 15 days. So, you can imagine the amount of data which is collected by this CGM device, but then it is difficult to interpret this data. This is just an illustrative diagram created using some AI tool. Now, if you take out these numbers and look at the readings of glucose, it will be something like this. In regular format, these are in millimoles, the values are in millimoles, these are different days and these are different time points. Now, for each particular time point, like suppose if you look at this time point, this 12 midnight, these are different readings of the glucose on different days. So statistically, you can take the median of these values. You can take the value which are the 25th centile, 50th centile, 90th centile, and 10th centile. So you get these 5 values: median, 25th, 75th, 10th, and 90th. And if you plot these, then you get something which is a AGP graph. So if you plot these 5 values for each time point, you get a graph like that, which is the AGP graph that we get through AGP software. So basically, by using AGP software, this complex data, we are simplifying that and summarizing that in the form of a chart like this. Now, to understand this chart, the orange line here in the center is of the median value of that particular time point. So, if you look at all the values over 15 days at this particular time point, this is the median value. Rest of the values, 50% of those values lie in this range, 25th and 75th centile. And remaining 90% lie from year to year. So the 10th and 90th centile. And still there are 10% values which are missed, which are not captured in the HP graph. You can see those only in the daily logs. This is the HP graph that we have spoken about. Again, just to revise, this is the median value that you see here in center. Then these are the interquartile values. So these are the 28th and 70th percentile curves. That is called as interquartile range. And here you get the 50% value. So 50% of the values lie in this particular zone, which is the most common zone. And then you have the interdocile range, where 80% of the data lies. 10% above that and below is missed by the AGP graph. Now, Julia showed you the Libre view, which is available to the doctors to see all the patients' records. So this is the way you look at the Libre view on your dashboard when you log in. These are the different patients that you see. You can see their last scan values, their last reported values, and so on. And then you get the AGP report. So for AGP report, again, you have the settings that you can customize. These are the standard settings. The target is for invalidity, but you might want to change it for a pregnant female or for a person who is at hyperglycemia. You can change those here. And there are some other changes in the report that you want to do. You can do those from here. After that, when you go to a particular patient profile, first you get a screenshot, glimpse of the patient like this. So here, looking at this only, I can see that the patient is doing very bad or very poorly in terms of the glycemic control. His average sugar is 249, and there are no hypos, but overall he's spending the most of the time in above range. Then, if you go to the details or the detailed report of the AGP, then you see these three components which are the important ones. First is the AGP report that gives you the metrics, which are the time in range, time above range, time below range. Then you look at the AGP profile, and this AGP profile, you want it to be a flat, narrow, in range curve. So this is a very wide curve. You want it to be a little flatter. It should be narrow. It should be flat. It should not have any variations, and it should be in the range. So this range is marked by the green lines in the graph. And the third part that we want to look at the easy daily views, where you can see the difference between the different daily profiles. You can pick out whether a patient is getting hypo on a particular day, or whether the hypos are on a particular day also. So again, going back to the ATP report, this is what is time in range that we want most of the patients to spend in 80 to 70 to 180, and then the time that is spent above this range is called as time above range, and then the time below is time below range. These are the three most important parameters, and the targets are there, which were discussed earlier for different patients, type 1, type 2, pregnant, and so on. So this is the AGP report of one of my type 2 patient based report that I could get, and this is something which we want for all our patients. So the first page of the report is something like this, where you see the TIR is very good information, 98%. He just has 2% variation in the time range, and then these are the other details. These are the targets that the same concentration. The average glucose value is so which is under 1 patient. Again, GMI you have spoke about, which earlier was used to call as EHbA1c, equivalent HbA1c. Now the new term is GMI, which is something like the HbA1c, but that is only for the period where the age value is improved. And then there is glucose variability. So in this case, it's 16.8. The ideal is that it maintains below 36% as the target for variability. Now the next component of the report that you see, again the AGP graphs like this, and then the daily glucose profiles. And here you can see the variation on the basis. You can pick up if the patient is having hyper or hypo on a particular day, and then you can try to find out the reason for that, which might be anything like excessivity or stress or anything like that. This another patient not doing so good, so I give example of the other side also. Here again it's a type 2 patient, but he is spending only is not having any time in range. Majority times he is having above range only. The average is 49. The GMI is 9.3. Variability is not that high. The report nowadays also gives you some clinical considerations. It will tell you for this particular patient, if it's a type 1 or type 2, what the clinician should look for and what the changes should be made in the patient treatment. Then the next component of the AGP report is the monthly summary. So here you get the calendar where there are different dates, and for each day you get different values. Like this value is the average glucose value for that particular day, and these are the sensor scans which are done by the patient. If the values are above the target which was set by you, then it will be in orange. If it is below that, then it will show in the red. So you can get a glimpse of the screenshot of the whole month, how the patient is doing throughout the month. Then in the daily logs, you can again see the details here. So for this particular patient, the target has been set high, and that is why you are seeing these higher values here, which are not picked up in orange, although they should be. And you can see which are the points where the patient is having hypos, and the overall graphs of particular days. For the whole 50 days or 30 days, whatever you have, you will get these graphs. The last component of the report is where you get the snapshot, in which you will have the AG profile, the summary here, and also if the patient is entering the carb content, the insulin doses, how much of effect insulin has taken, how much of non-insulin has taken, all those will be recorded. If there are the low glucose events or hypo, those will be recorded here. So you get a list of the AGP, the carb intake of the patient, the different insulin doses, the hypos, and the effect of these doses on the AGP profile also. Then you also have the weekly summary, where again the daily chart is here, and for each day you get the average glucose, the hypo events if any, and then the total carb intake and the insulin intake, and you can interpret based on the glucose and carb intake how the sugars are there on the daily graph. Again the daily patterns here, and everything is summarized here. Now, so this was what you see in the PDF report if you take the full report of the AGP from the Trivandrum software. So what are the real world actions that you should look for? So there are three components. that we must understand variability, stability, and exposure. I will try to clarify these concepts to you in the different slides. So this is the ADB profile application, and this is the median graph, median curve of the different values throughout these 14 days. So the exposure of glucose is uh, uh, the amount of time the patient, the amount of glucose that the patient is exposed to, and that is what is exposure. So more the exposure, more is the GMI, more is the HbA1c, more are the causes of complications. The second component is the variability. Variability basically means the difference in the value of glucose on at the same time point on day-to-day basis. So at the same time point on a particular day it has got 350 value, and on the other day it has got as low as 70 or 80. Which means that the day-to-day variability is very high. The uh, the graph is very wide, which we want to be narrow. So that is what is variability. And then if you look at the same thing on a intraday basis, then that is called as stability. So on an intraday basis, if there are a lot of fluctuations, if the sugars are going up and down, then you say that the stability is not really good. So these are the two things that we need to do for. Exposure should be minimum. The variability should be minimum, which can be seen by having a narrow graph, and stability by a flat line, not having too many peaks and troughs. That is what our target is. So when you have a patient like this is the target that we have, which is the time of range, and these are the time above range and time below range. So how do you treat this patient in the clinic? So the first thing that you should try, because the patient is having a lot of variability, this should be the thing that you address first. Because if you just look at the higher values and intensify the treatment, the patient might end up with hypoglycemia because the sugars are normal on certain days. And that is why we should first try to minimize this variability. This variability can be because of his non-muscle activity disease, poor lifestyle, erratic meal intake, poor adherence to lifestyle or exercise. So all these things we should first address. First, the patient should have the medicines properly on fixed time, the meals on fixed time, and all those things, and then try to make this very wide graph a little narrow one. That is the first target. So we shall first try to target the variability. Once you do that, after that you look for the the stability. So here you can see that the patient on all the days, the median value is actually as after breakfast. So after breakfast there is a peak. So first target is to narrow down this, and then we want to flatten this. So there is a peak at the post breakfast time. So we either make some changes in the medicines, or we ask the patient to divide the breakfast into two, or take something like an AGI, or we want some bonus doses and increase the bonus dose, and try to flatten this curve. That is second target, and if you achieve that, the third one I can't show you because I tried to get it to here. I have to bring this graph down. So first you make it narrow, then make it flat, and then you bring it down so that you can bring down the exposure. So that is how clinically we manage patients looking at the graph. So the learning points from this particular presentation are that if you are using CGM, you should know how to read the AGP report, and I tried to show you some components of the report which are important. While reading the AGP report, the important parameters that you look for are TIR, PAR, and TBR. Now there is a new concept that is STING, which was presented in the ATTD. Still there is no concept of that, which is type in normoglycemia, where the range is even narrower. And then after that, you want to make some changes in the patient's treatment. Then you look for the variability. First, try to bring down the variability. Then
I can see clearly is that here, most of the time the patient is in PIR. You have only this peak here, and in that also the median is just reaching the PIR, so it's only 180. Just a few values are there which are above the range, and these are the values which are rarely seen. So these are the interdocile range values, right? And that is why I think the PIR is that good in the patient, because otherwise you don't see anything going beyond the 180. Even the median is here at the 180 only. So clinically for this patient, one is that there is a lot of variability in the time. So probably the breakfast time, he has got a lot of variation. Sometimes he has got a good breakfast, so the sugars are okay. Sometimes the breakfast is carb heavy, so the sugars are high. So that probably very too. Julia, want to add something?